Welcome to your Neuro Medications Part 2 lecture. First, I'm going to start with medications for depression coming from Chapter 8 in your textbook. And the first medication class that we're going to just talk about is the selective serotonin reuptake inhibitors, SSRIs. So our examples here listed are paroxetine, sertraline, escitalopram, and fluoxetine. These are going to allow more serotonin to the neuron junction without blocking uptake of dopamine or norepinephrine and has a longer half-life. We've already kind of reviewed these in another section. Just make sure that you understand that these can also be used for depression and watching for your serotonin syndrome and the same other symptoms, bruxism, withdrawals, things like that. Now the next medication are the SNRIs. These are the serotonin norepinephrine reuptake inhibitors. Examples I've got listed are duloxetine and venlafaxine. These are going to block the reuptake of norepi and serotonin, which results in similar effects as SSRIs to treat major depression and severe anxiety disorders. So because we're still dealing with serotonin, we also have the risk here of serotonin syndrome. Now the other norepinephrine comes with its own other additional side effects, such as dizziness, blurred vision, nausea, anorexia, weight loss. So that's a little bit different. Headache, insomnia, anxiety, and sexual dysfunction. The sexual dysfunction can be like anorgasmia, and the inability to orgasm, decreased libido, impotence, and menstrual changes. So definitely want to make sure that they're aware of this as a potential so that when it does start happening, they don't feel like something's wrong with them, that it could be as simple as changing their medicine. So next are the atypical antidepressants. There's three major categories here, so that's why they're kind of split up this way. So first, bupropion, which is the generic for Wellbutrin. These ones are going to inhibit norepinephrine and dopamine uptake for treatment of depression. These are going to be the alternative that we resort to when a client taking SSRIs or SNRIs are unable to tolerate the medication, either due to that sexual dysfunction concern or that they have now had an episode of serotonin syndrome or been suspected of. So this is kind of what we resort to, but they can then have some like headache, dry mouth, GI distress, constipation, increased heart rate and high blood pressure, restlessness and insomnia, but it's not, of course, as severe as serotonin syndrome. Weight loss, anorexia, so here's a little bit different, and then seizures. So if they have a history of seizures, of course, don't use this one. And don't take with MAOIs within 2 weeks. It's going to be kind of a general rule of thumb. The second grouping here, example, is vilazodone. These are going to block serotonin and work as a serotonin agonist at the receptor sites, but these can lead to suicidal ideations as well as serotonin syndrome. So these are going to be contraindicated for any other clients that are also taking SSRIs or SNRIs, so don't take these at the same time. Other serotonin receptor agonist, which is what bupropion is, or MAOIs within 2 weeks. Avoiding grapefruit juice, of course. Usually grapefruit juice blocks that enzyme, and therefore there's too much medication in the body, so it's kind of like an overdose if they take grapefruit juice. Make sure that they're taking it with food in order to help with absorption in this case as well. Trazodone ER, the third category here. These are going to selective blockade of serotonin receptors, allowing more serotonin to be available for transmission. It's usually used in combination with another antidepressant. But this can lead to some sedation, which may be the reason that this might be a good choice for them, actually. So if they have depression and insomnia, then trazodone might be a great choice for them because of the sedation effect. But priapism is not. This is a medical emergency. They should seek attention immediately. This is a prolonged erection of the penis and a persistent erection that continues hours beyond sexual intercourse or isn't caused by any sexual stimulation. It's usually very, very painful for the male, and it's usually not very common except for as a side effect of medication, but it can be more common in those with like sickle cell anemia and other chronic issues. So what happens is that they'll have to seek emergency medical attention in the emergency room, and yes, I have seen this. There's a whole special kit for these males that come in and involves the syringe that you see here. It's a special needle gauge and length I can't think of off the top of my head because it's already pre-made in the kit, and you assist the physician with essentially sort of deflating the penis. You're not putting it into the blood vessel as you see on the top and the bottom, but it is going into the muscular area and trying to stop the contraction that is leading to the prolonged erection. So once the contraction has stopped and the penis becomes flaccid, the pain usually resolves, and usually color returns as well because of the prolonged contraction. It can actually shut off some blood flow to the tip. So it's usually a great relief for these clients. Also, in this case, grapefruit juice can also lead to toxicity, so avoiding that as well. Tricyclic antidepressants such as amitriptyline. These are going to block norepinephrine and serotonin in the synaptic space, therefore intensifying their effects. These are going to be also used to treat depression as well as bipolar disorders. But off-label, we can also use these for neuropathic pain, fibromyalgia, and anxiety. But come with its own sort of side effects, such as orthostatic hypotension, which is kind of a common theme in this area for antidepressants. Anticholinergic effects also, but you also have your eye issues and cardiac issues, so more of the severe side of anticholinergic effects. And then also sedation, but this usually diminishes after a few weeks, so this shouldn't be a long-term problem. Just make sure in the beginning of their treatment that they're aware of this as a concern and not, driving. Toxicity can also occur due to a cholinergic blockade that causes dysrhythmias, confusion, agitation, and then can lead to seizures, coma, and death. So watching out for those early symptoms, watching their EKGs, their vital signs, and making sure that we're telling the physician. And it can also cause a decreased seizure threshold. So epileptic clients are more likely to have a seizure because if their threshold is being increased by their medication that they're taking as an anti-epileptic medication, but then they're on a tricyclic antidepressant, it's going to bring that threshold back down, and it's going to be easier for them to have that seizure. So contraindicated for these clients. No for these clients. And then also excessive sweating can occur. So avoiding dehydration is going to be a main key of education here due to the anticholinergic effects and the sweating and the increased risk for hypotension, orthostatic hypotension. Make sure they're not taking this if they're pregnant or breastfeeding. This is another medication that we're going to only give them a 1-week supply of at a time because of a lethal toxic dose until their levels have normalized and they're a little more stable so that they're not going through a bout of suicidal ideations and take all their pills. Avoiding with MAOIs as well, because this can increase their hypertension and hypertensive crisis, which we'll go over in a minute with MAOIs. And then avoiding with antihistamines and anticholinergics due to the dehydration, and other CNS depressants due to the sedation. MAOIs. All right, the big hoopla all about MAOIs. Monoamine oxidase inhibitors. The example here is phenelzine. These block MAOI enzymes to increase the amount of norepinephrine, dopamine, serotonin, and tyramine for impulses to relieve depression. However, this can lead to high blood pressure or hypertensive crisis, headache, nausea, tachycardia. These are usually due to tyramine, so education about dietary and medication restrictions to avoid items with tyramine. Administer phentolamine IV or nifedipine to counteract these symptoms, especially the hypertensive crisis, and continuous cardiac monitoring and respiratory support as needed. CNS stimulation can also occur, so they may show some anxiety, mania, hypomania, which is like a mania but not so severe, but still make sure that they are reporting these to their doctor. Orthostatic hypotension can also occur. And then with younger clients, suicidal ideations may be present. It may take 1 to 3 weeks for their effect, and therapeutic effects can take 2 to 3 months. Contraindicated with SSRIs, tricyclic antidepressants, antihypertensives, meperidine, vasopressors, anesthetics, pregnancy, seizure or diabetic history, which is like everything that we've already discussed. These don't play well with others. They don't like to share. So avoiding tyramine-rich food. So some examples here are aged cheese, pepperoni, salami, avocados, figs, bananas, smoked fish, protein supplements, soups, soy sauce, some beers, and red wine. The patch version of MAOIs may not have as many tyramine effects as the oral version. And suddenly stopping this medication can result in relapse of symptoms. So if we're taking this for depression and we suddenly stop, our depression can rapidly reoccur. So make sure that they're taking it for 6 months to a year after their symptoms resolve. So don't let them, well, I haven't had any episodes of depression, I haven't been suicidal, for a month or so, and this medication is really expensive, so I'm gonna just come off of it. To keep those levels normalized and leveled out, they still need to be on it for 6 months to a year, and that's going to be up to the doctor, so they don't immediately relapse into those issues that they were in before. Next, we'll go into medications for bipolar from Chapter 9. All right, so mood stabilizers. Mood stabilizers, the main one here we're going to talk about is lithium carbonate. These control episodes of acute mania and prevent the return of mania or depression, but can cause some goiter or hypothyroidism. So some endocrine issues here. So cold, dry skin, bradycardia, and weight gain is going to be our little keys, our cues here, and make sure that we're notifying the provider because we don't want this going on long term. Otherwise, there's usually some mild symptoms that usually resolve in about 2 to 4 weeks. That is nothing really major to think about. But then lithium toxicity. Early signs and symptoms start around 1.5. Advanced signs and symptoms start at a level of 2.0. And severe toxicity starts at 2.5 or higher. So at first we just get some diarrhea, nausea, vomiting, some extra thirst, polyuria, muscle weakness, maybe some hand tremors, slurred speech, and lethargy. These are the early warning signs, not early toxicity, but early warning signs that they're heading towards toxicity levels that these clients need to be very aware of to notify their physician. Then in the early toxicity stages, more GI distress, nausea, vomiting, diarrhea, confusion, poor coordination, coarse tremors, and sedation. If these are happening in the hospital, make sure we're withholding the medication at this point. We don't want to give them more medication, of which they are now toxic. The next level for advanced toxicity, we now have more polyuria with very dilute urine, tendinitis, involuntary movements, blurred vision, ataxia, seizures, severe hypotension, coma, death, and from respiratory complications. We may not even get to the severe area. In advanced area, we may still die from. But then if they somehow still manage to be alive with levels of greater than 2.5, now we're going to oligoria. Their kidneys are shutting down. They're having seizures and rapid progression up to death. This will happen very quickly. And at this point, there's nothing really else to do but hemodialysis. Flush it out of their system. We're going to make sure when they are on this medication, due to this high risk of toxicity, that we're drawing their levels 1 to 2 times a week until they're therapeutic. And then at that point, they'll switch to monthly. And then once they're therapeutic still for a while, then every 2 to 3 months. So patients need to be very aware that, yes, on this medication, for their mania, they will have to get their blood drawn. If not, these things can happen. And we need to make sure that we're monitoring this very, very closely. Also, adequate fluid and sodium intake are important during this time, and avoiding conditions that can lead to dehydration. If a client that's taking lithium becomes dehydrated, they can easily resort to lithium toxicity. If they had a normal level yesterday but got dehydrated at the ballpark today, they can then be in toxicity. Next, we have mood stabilizers for antiepileptics. So we have 2 kind of different sections here. Carbamazepine and valproic acid. Both of these are going to be used for clients with mixed mania and rapid cycling bipolar disorders. For carbamazepine, we have some CNS effects. Make sure you understand what the difference of like ataxia, nystagmus, staggering gait, all these different terms mean, especially when we get into the Parkinson's medications. Make sure you know what these terms are. So with here we have the nystagmus, double vision, vertigo, staggering gait, and headache. Nursing wise, this is why we're going to give them low doses initially and then gradually increase their dose, and potentially giving them this at bedtime so they don't have as much effects during the day. This can also potentially lead to blood dyscrasias, which is going to show as leukopenia, anemia, and thrombocytopenia. So they need to know to report sore throat, fatigue, or indications of any infection or bleeding. This medication is also a teratogen, so avoid during pregnancy so it does not lead to birth defects in the infant. And then hypoosmolality, so make sure that we're monitoring sodium levels, watching for edema, a decreased urine output, and high blood pressure. They may also develop skin disorders such as dermatitis, rash, and Stevens-Johnson syndrome. So we need to educate them to make sure that they're wearing sunscreen. If they're having only a mild skin reaction, they can take an antihistamine or an anti-inflammatory. But if they actually develop like the Stevens-Johnson syndrome type skin rash, they need to make sure that they stop the medication. Hepatotoxicity, so liver issues, and make sure that we're avoiding this with oral contraceptives and warfarin. Now with valproic acid, they can have also the liver toxicity, but also pancreatitis. You can also have the thrombocytopenia here, but it's usually on its own and not in association with the blood dyscrasias. We also have weight gain, some GI effects, but we'll make sure that we're avoiding this with phenytoin and phenobarbital. We don't want to mix these together. Now, chapter 10 for medications for psychotic disorders. So, for psychotic disorders, we have lots of different categories. So first are going to be the first generation antipsychotics. So these are going to be chlorpromazine and haloperidol. These block dopamine. In this category, what you're going to mainly see are dopamine and acetylcholine. Okay, so these are going to block dopamine, acetylcholine, histamine, and norepinephrine to inhibit psychotic manifestations. But what can happen with these are extrapyramidal side effects, EPSs. And so I would make sure that you are very familiar with EPSs. If not for my class, also for Miss River's class. So acute dystonia. Acute dystonia is spasms of the tongue, neck, face, or back. And if the laryngeal muscles are then affected, respirations can be decreased and resulting in the need for rapid intervention and intubation. So therefore, during the first 5 days of treatment, we need to monitor for this. We can treat with anticholinergics, benzotropine or diphenhydramine, with the expectation of the improvement within 5 minutes if we gave it IV or 20 minutes if we gave it IM. If it has not improved, notify the physician immediately. Sometimes EPSs can convert to long-term, so we need to make sure that we're intervening on these as soon as possible to try to reverse these so these are not permanent problems for these clients. The next EPS here for first generation antipsychotics is going to be Parkinsonism or pseudo-Parkinsonism. So symptoms that's going to mimic Parkinson's, but they don't have Parkinson's. This is what this means. So bradykinesia, so very slow movements, rigidity, shuffling gait, drooling, and tremors. You're going to monitor for this during the first month, and we can treat with benzotropine, diphenhydramine again, or additionally here we have amantadine. If symptoms return after we have treated them, we may need to administer an atypical antipsychotic, either in its place or in combination. The third EPS is akathisia. This is the inability to stand still or sit because they're continuously pacing or agitated. Monitor for this during the first 2 months. And we can treat with a beta blocker or benzodiazepine or anticholinergics. And then tardive dyskinesia. These are involuntary movements of the tongue and face, such as lip smacking, which can lead to speech and even eating disturbances. This can even progress to the arms, legs, or trunk for the spastic involuntary movements. Monitor for this for the first 12 months. It can be temporary, or again, this can move to a permanent problem for them. For this one, we can treat with valbenazine for adult clients. If this is a pediatric, I am not aware of a medication that we can treat this with. So Furthermore, aside from EPSs, these antipsychotics, first generations, have other symptoms and complications. Neuroleptic malignant syndrome can be a life-threatening emergency, includes a high-grade fever, blood pressure fluctuations, dysrhythmias, muscle rigidity, diaphoresis, tachycardia, change in level of consciousness, and coma. So here's a little mnemonic here for fever related to neuroleptic malignant syndrome. This is very similar to serotonin syndrome, but you have your elevated enzymes for the CPK because this is more muscle related. If these occur, we're going to stop the medication, monitor their vital signs, of course, apply cooling blankets because of their high fever, just as with serotonin syndrome, administer antipyretics, increase their fluids, administer diazepam, dantrolene, bromocriptine, antidysrhythmics, transfer them to ICU, and wait 2 weeks. Here's the difference. Wait 2 weeks before restarting therapy, or consider an atypical agent. So be familiar with neuroleptic malignant syndrome. These ones also have anticholinergic effects, neuroendocrine effects, sexual dysfunction, sedation, seizures, agranulocytosis, refresh your memory on that, severe dysrhythmias, and liver impairment. They also have the skin effects here, so make sure they're with their sunscreen and other items that we mentioned in another area would also apply to these. And then these medications are going to be contraindicated with levodopa, which we'll go over in a moment, CNS depressants, and anticholinergics, because we already have the anticholinergic effects. Remember, no double whammies. It can take 2 to 4 weeks and possibly several months for full effects. Next, we have the atypical antipsychotics, otherwise known as the second and third generation medications. These include risperidone, olanzapine, quetiapine, and clozapine. I picked these 4 out because these are the 4 that I've seen. I've not ever seen the others. These are the first-line treatment for schizophrenia due to fewer adverse effects and EPSs. So these don't really have EPSs. So first generations have them, second and third don't really. But they come with the potential for diabetes. This could be a new onset diabetes during this medication, or if they already have diabetes, they could lose their glucose control. They could have weight gain, increase in their cholesterol, orthostatic hypotension, again, very common theme. Anticholinergic effects, very common. Agitation, dizziness, sedation, and sleep disruption could occur. And mild EPSs like tremor or akathisia. And we're going to use an Ames assessment to screen for EPSs, and I'll give you all an example of an Ames as well. They could have elevated prolactin levels, not just females, but also males is a potential. So make sure that we're looking for galactorrhea, gynecomastia, and amenorrhea. Make sure they're notifying their doctor. They could also have sexual dysfunction. So they may consider adjunctive meds to improve their sexual dysfunction. And an example here would be sildenafil. And avoid with immunosuppressants, barbiturates, phenytoin, fluconazole, levodopa, antihistamines, opioids. Remember, no double whammies. Several weeks can be needed for therapeutic effect. Oral preparations are usually used until their IM is being effective. So they may have an oral dose and a weekly IM until their IMs have reached therapeutic level, and then they might be able to come off of the PO. Effectiveness can be noted when they no longer have positive or negative manifestations. So positive is symptom that was added to them, versus a negative is that's a symptom something has been removed from them. So make sure that you understand that with chapter 10. For on page 73, it talks about the different types of positive versus negative manifestations of psychotic disorders. And I'm sure Ms. Rivers will need you to know that as well. So positive being adding and negative being something taken away. So hallucinations would be a positive manifestation, versus a negative manifestation would be like lack of energy or a flattened affect. It's been taken away from them. As well, so other effectiveness can be noted by that they have had a normal sleeping and eating pattern now, and they are able to interact socially with peers. And then now we are moving on to chapter 13 for other chronic neurologic disorders. So first we're going to talk about cholinesterase inhibitors. So here is your neostigmine, which we have used as an antidote in Neuro Part 1, remember? So these are going to prevent enzyme cholinesterase from inactivating acetylcholine, increasing the amount of acetylcholine at the receptor sites, thus increasing the response to acetylcholine. But we have some excessive muscarinic stimulation that can happen. Remember your muscarinic medications. So if it's excessive, we can have the increased in GI motility, secretions, diaphoresis, salivation, and urinary urgency. And then we have cholinergic crisis, which you'll see here as a mnemonic as sludge, salivation, lacrimation, urination, defecation, gastric upset, and emesis. So this is due to, again, the excessive muscarinic stimulation and respiratory depression leading to paralysis of respiratory muscles, in which case can be fatal. So we may need to provide mechanical support, respiratory support, oxygen support, and administer atropine in order to reverse this. It's going to reverse the cholinergic response. And these are going to be contraindicated for any clients that have recently received succinylcholine. And if they are on this as a long-term medication like donepezil, make sure that they are wearing a medical alert bracelet because of this high risk of the cholinergic crisis considerations. Next, we have anti-Parkinson's medications. I've kind of separated these, so this portion of these medications are going to be the dopamine synthesis meds, such as levodopa and carbidopa. These do not halt the progression of Parkinson's, but offers the client relief of the dyskinesias and increases their ability to perform the activities of daily living by balancing the dopamine and acetylcholine in the extrapyramidal nervous system. Levodopa crosses the blood-brain barrier and converts to dopamine to balance dopamine and acetylcholine, whereas carbidopa is used to augment levodopa by decreasing the amount of levodopa converted to dopamine in the intestine and periphery, resulting in larger amounts to then be converted and used in the central nervous system instead. So these may be used in conjunction. These can then, therefore, watching out for some nausea, vomiting, and drowsiness. So educating them to administer with foods in small doses, but avoiding food high in protein as this delays absorption. So you have your picture here about foods with high protein content. So don't take this medication with these. We'll also want to avoid pyridoxine. It's always a difficult word for me. And examples here are wheat germ, green vegetables, bananas, whole grain cereals, liver, and legumes. These can also have signs of dyskinesia. It's usually different than the initial dyskinesia types that they're taking it for. but looking for, again, different types of dyskinesia like head bobbing, tics, grimacing, tremors. If this happens, we may need to decrease their dose and administer amantadine in order to decrease the effects of these dyskinesias. Orthostatic hypotension, of course. Cardiovascular effects such as tachycardia, palpitations, and irregular heartbeat can occur. And psychosis. So visual hallucinations, nightmares, paranoid ideation can occur. So these would be like positive manifestations. So switching to a second generation antipsychotic may be indicated for these clients as they don't have as many of those symptoms. Avoiding conventional antipsychotics such as haloperidol in addition to taking these medications, as these can intensify the psychosis side effects. So if someone is being paranoid and acting weird and psychosis type, usually in the emergency room we might resort to haloperidol. But if looking on their medication history and you see that they are on levodopa or carbidopa, haloperidol is actually going to make it worse. It's going to intensify their psychosis. So being aware of that. And of course, avoiding MAOIs, as this may lead to a hypertensive crisis. Another harmless side effect is going to be discoloration of their sweat and urine. So just being mindful of that and educating them about that. But this medication also may activate malignant melanoma. So if they have some skin lesions that have not been diagnosed, maybe they should see a dermatologist before getting on this medication. Next, we have the dopamine agonists, such as pramipexole, bromocriptine, and ropinirole. These are going to activate dopamine receptors, but can lead to the sudden inability to stay awake. They're that drowsy. Then daytime sleepiness, orthostatic hypotension, psychosis again, dyskinesias again, and some nausea. The difference here is going to be the impulse control disorder. So suddenly, they now have a gambling, shopping, binge eating, hypersexuality. They're focused so much on something, and that they just cannot control their impulses. They cannot, if they're, given a wager or a bet, like you see in this picture, he's gambling his wedding ring. This is impulse control. They cannot control themselves anymore. They cannot say no. Next area are going to be the catecholamine O-methyltransferase, the COMT inhibitors, such as entacapone and tolcapone. These enhance the effect of levodopa by blocking its breakdown. These are going to have the same as pramipexole when used with levodopa, so you got the same symptoms. And then also GI discoloration of the urine, which is going to be yellow-orange, but it's still harmless. But additional here we have new is the rhabdo, so watching for that muscle pain and tendon weakness, that CPK levels. And then you have your liver failure, so watching for nausea, fatigue, jaundice, and abdominal pain. And then we come to monoamine oxidase B inhibitors, so like selaginine and rasagiline. These are going to prevent dopamine breakdown also, but can come with insomnia. So administering it prior to noon so it doesn't interfere with their actual sleeping cycle. They may lead to a hypertensive crisis though, if they do take it with food containing tyramine. So now we need to know tyramine foods again. So this is going to, or within 2 weeks even after taking the medication. So here's your picture of all the crazy tyramine foods. So avocados, soybeans, figs, smoked meats, dried or cured fish, cheese, yeast products, beer, Chianti wine, chocolate. Chocolate's a big thing, and caffeinated beverages. Hypertensive crisis with other medications as well, and then nausea and diarrhea. So making sure that they take it with low protein meals again. And then we have dopamine releasers such as amantadine. These are going to prevent dopamine reuptake and block cholinergic and glutamate receptors. Can lead to some CNS effects though. Usually we can reverse these or counteract them. But we also have like atropine-like effects. So like exaggerated anticholinergics, okay? So dry mouth, blurred vision, mydriasis, which is dilated pupils because there's like no more fluid in their eyeballs, urinary hesitancy or retention, and constipation. And then we have discoloration of the skin, which is this unique looking thing, livedo reticularis. It's obviously very concerning looking, but once they come off of the medication, this usually goes away. And then the last area, I believe, is the anticholinergics we can use to treat Parkinson's. These block the muscarinic receptors again to maintain balance between the dopamine and acetylcholine, but can lead to some nausea and vomiting, some atropine effects, so make sure they're staying hydrated and they've got that eye exam scheduled, and then some antihistamine effects, especially in older adults. So hot as a hair, dry as a bone, blind as a bat, red as a beet, and mad as a hatter. Or is another little mnemonic here. Not really a mnemonic, but maybe a picmonic to help you remember some of these anticholinergic effects, which are going to be common as you saw through most of these medications. And then we have antiepileptic drugs. These are going to include phenobarbital, phenytoin, carbamazepine, valproic acid, lamotrigine, levetiracetam, topiramate, pregabalin, gabapentin, and oxcarbazepine. These are going to suppress the neuron firing, thus decreasing seizure activity and preventing, therefore, seizure activity. And therefore, and by doing so, it is also slowing the frequency or time that the neurons are firing off, therefore less likely to develop into a seizure. These come with some CNS effects, maybe a little bit different in older adults than in children. We also have some toxicity, so nystagmus, double vision ataxia, can lead to coma, pinpoint pupils, and death. Make sure that if we suspect any of this, that we're stopping the medication, supporting them respiratory-wise, and resuscitating them if needed. Unique to this medication, these types of medications are gingival hyperplasia, so softening and overgrowth of the gum tissue, tenderness and bleeding of the gums. So make sure that they're maintaining good oral hygiene, and folic acids they can add to their regimen in order to help decrease these risks. Some other effects such as coarse facial features, hirsutism, vitamin K and D metabolism interference can also occur. And then we have blood dyscrasias, again, it's come up. Some skin issues, some liver, pancreatitis, hyperammonia issues, and then we have aseptic meningitis. So this is going to be seen as headache, fever, stiff neck, nausea, vomiting, rash, sensitivity to light. This is going to be specific to the lamotrigine medication only in this category. And then weight gain, peripheral edema, dry mouth, and angioedema is going to be specific to pregabalin only. And then we have medications for status epilepticus. This is an acute prolonged seizure, and our examples are going to be diazepam and lorazepam, trying to immediately increase that threshold on that seizure to stop that seizure in its tracks. So again, comes with the CNS depression, paradoxical response, because these are benzos, remember. We're using a benzodiazepam to stop status epilepticus, okay? But remember your IV toxicity for respiratory depression and cardiac arrest, that we have our reversal for flumazenil. So these came from your ATI textbook, 8th edition, chapters 8, 9, 10, and 13. Thank you.